Hello, my name's Kate Chesterman. I'm a GP in South Norfolk and I also co-host the GP Notebook Education Study Groups. Today I'm going to be talking about statin intolerance. And my main resource for this talk and this video is the statin intolerance pathway that has been produced by NHS England. Now this pathway brings together multiple NICE guidelines and a significant number of technology appraisals as well. And the idea of this pathway, this guideline, is to try and to support us all in primary care in delivering a consistent approach to the management of statin intolerance. So the main questions that we're going to be looking at throughout this video is firstly, what is statin intolerance and working out a definition for that, and then looking at some different approaches to statin intolerance. So first of all, thinking about some statin-based approaches, and then some alternative options if statins really cannot be tolerated at all. So I just thought we'd start with a case study. This is the case of David, who's 52. David's got a history of hypertension and pre-diabetes, and he takes lisinopril 20 milligrams a day. He was noted to have a Q risk of 22, and so 2 months ago he was started on atorvastatin 20 milligrams. He comes to see you now, unfortunately concerned that he is noticing increasingly achy thighs, and this is particularly bad when exercising and is particularly interfering with his golf. So what would you do if faced with David in your clinic? Would you stop the atorvastatin? Would you check his creatinine kinase? Would you advise him to stay off statins in the future and to modify his lifestyle? Or would you try an alternative medication? And just as a follow-up question to that, if you were going to try an alternative medication, what alternative would you try? Would you try simvastatin, pravastatin, maybe ezetimibe or inclisiran? So just a few questions to think about as we go through this topic, and we'll revisit David's case towards the end of this video. So first, a little bit of background. Statins are oral hypolipidemic drugs, and they are the first-line hypolipidemic drug for managing cardiovascular disease risk. And because of their affordability and availability and our widespread experience with using these medications, they are likely to remain the first-line hypolipidemic drug for the foreseeable future. There is really good evidence for their use, so substantial evidence for a reduction in morbidity and mortality due to cardiovascular disease with statin use. And they have additional benefits as well. So they've been found to have anti-inflammatory, antioxidant and immunomodulatory effects, as well as inhibiting platelet activation and increasing plaque stability. Now, interestingly, in trials, statins are usually found to be well tolerated. However, up to 75% of those started on a statin stop it within 2 years. And obviously stopping that statin then reverses that reduction in their morbidity and mortality risk. So they then have an increased risk of major cardiovascular events and mortality. So the question is, are we labelling patients as statin intolerant too quickly? Are we giving up on statins too quickly in some patients? Are we allowing patients to give up on them too quickly, given the benefits we know are associated with their use? I think we need to be aware of the effect of negative media coverage. It sometimes feels we don't go through a week without another report of problems associated with statins, and this obviously has an effect on our patients. There is also this idea of the nocebo effect. So the nocebo effect is negative expectations of the medication by the patient, leading to increased reporting of adverse events compared to placebo. And in addition, there is a significant amount of statin reluctance, which is an attitudinal aversion to taking statins, often without even trying them. And this can be due to that negative media coverage, but also due to negative reports from family or friends who have maybe tried statins and had side effects. So, what is statin intolerance? Well, statin intolerance is defined as clinically significant adverse events attributed to statin therapy that represent an unacceptable risk to the patient and reduce compliance with treatment. And these adverse events can either be unacceptable symptoms or laboratory abnormalities. Statin-related muscle toxicity, or SRM, is the most commonly reported statin adverse event and one of the commonest reasons for stopping statins. It comprises around 2/3 of all adverse events associated with statins, and it's going to be the main focus of the rest of this talk. The most common muscular symptoms are pain, heaviness, stiffness, and cramps, sometimes with subjective muscle weakness. Symptoms generally involve the leg muscles most frequently, although back, neck, shoulder, and generalized muscular symptoms have also been described. The symptoms tend to be symmetrical and worsened by exercise. And importantly, these symptoms should be proved by resolution on stopping the statin, but also with a recurrence or return of those symptoms when we restart it. And this is one of the real focuses of the statin intolerance pathway, is that we should not just be stopping a statin, seeing those symptoms improve and saying that it is the statin that caused them, but we should be re-challenging. We should be restarting a statin and seeing if those symptoms return. Now, a quick note on non-statin related musculoskeletal symptoms, because despite what we hear in the media and despite what patients may tell us, not every musculoskeletal symptom is due to statins. Remember the nocebo effect, remember the negative media coverage and statin reluctance. Symptoms that are asymmetrical or fail to resolve on stopping the statin despite the patient having a normal creatinine kinase are less likely to be due to statins. And in these situations, we want to be considering alternative causes and differential diagnoses, so things such as vitamin D deficiency or polymargia rheumatica. So we might want to consider checking bone profile, vitamin D and CRP in these patients. Now, can we predict who is most likely to experience statin-related muscle intolerance? Are there patients who are at increased risk who maybe we want to treat slightly differently? Well, interestingly, it has been shown that several factors do predispose to SRM, including being female, advanced age, increasing frailty, a history of muscle disorder or a raised creatinine kinase, deranged renal or hepatic function, a personal or family history of statin intolerance, and hypothyroidism. And in addition, patients are increasingly likely to suffer with SRM if they drink heavily, if they undertake high-intensity exercise or become dehydrated, with certain drug interactions, including some herbal remedies, and with vitamin D deficiency. So the suggestion from the guideline is that we should consider checking a baseline thyroid function, liver function, and renal function prior to starting statin therapy. We should check their history for any potential drug interactions, asking about over-the-counter remedies as well. And if we think a patient is at higher risk of developing SRM, then avoid high doses, particularly at initiation. If we can get a patient established on even a small dose of statin, we can always increase that later. And this is something we'll come back to in a few slides' time. It is suggested that we should not routinely check CK prior to starting a statin unless the patient has generalized unexplained muscle pain. And if we do check a CK for this reason, we should not start a statin if the CK is more than 4 times the upper limit of normal. That would need investigation in its own right. Because patients can have a raised CK for a number of reasons. It can be a normal variant in some patients, can be due, as we've already said, to exercise or dehydration, muscle trauma from seizures or surgery, certain drug interactions, endocrine disorders, autoimmune or inflammatory myopathies, or thiamine deficiency. So an unexplained raised CK more than 4 times the upper limit of normal, as I say, needs further investigation. So I think it's worth pointing out that SRM is not a single entity, but is actually a spectrum ranging from mild and tolerable myalgia to severe rhabdomyolysis. And so obviously our management is going to depend on the severity of the symptoms and also on the patient's creatinine kinase levels. So we are encouraged to measure creatinine kinase in all patients presenting with possible SRM. And I personally always add on using these, so I'll do a renal function as well in any patient presenting with possible SRM in case of the possibility of rhabdomyolysis. And again, we'll come back to this in a couple of slides' time. So this is what that spectrum looks like. As you can see, it ranges from SRM0 to SRM6. And as we go down this spectrum, the conditions become increasingly severe, but also thankfully increasingly rare. So SRM0, which is an asymptomatic CK elevation with a CK less than 4 times the upper limit of normal. This does not preclude statin therapy. We can start statins in these patients, but we might want to consider starting at a lower dose and increasing as tolerated. SRM1 is tolerable myalgia, so these are mild muscle symptoms that the patient can cope with. We would check a CK in these patients, and in SRM1 there is no CK elevation. With this condition, we would expect an improvement in those symptoms within 2 weeks and a complete resolution of that muscle discomfort within 6 weeks. With all patients presenting with SRM, we should be evaluating those risk factors for SRM, going back, checking that drug history, checking on any other conditions that might predispose, looking for any other causes of muscular complaints, reviewing the indication for statin therapy. Are we still happy that statins are the right choice? And reinforcing lifestyle changes. And then with SRM1, if the patient's happy and the symptoms have completely resolved, we can continue that statin therapy. If the symptoms are not improving, or if the patient's not happy to continue, then we would treat as for SRM2 or 3. So SRM2 is intolerable myalgia, so more severe muscle pain with a CK less than 4 times the upper limit of normal. SRM3 is myopathy, so these patients again have muscle pain, but a CK between 4 and 10 times the upper limit of normal. In these patients, we should be stopping their statin therapy for 4 to 6 weeks. It's good practice to document the time it takes for the symptoms to resolve. Again, evaluate those risk factors, look for other causes, check the indication for statin therapy, reinforce those lifestyle changes. And then we need to make sure that the CK has normalized. So after 6 weeks, we recheck a creatinine kinase, and we also make sure that the patient has been symptom-free for 2 weeks. Provided the CK has normalized and that the patient has been symptom-free, we can consider restarting a statin, but probably with a lower dose or an alternative statin. And this is where we come to our statin-based approaches. So I think it's worth pointing out that for all the suggestions, or for some of the suggestions made in the statin intolerance pathway, the cardiovascular benefits have not been fully proven. However, it is generally felt that any reduction in cholesterol is beneficial, and therefore a low dose of statin is preferable to no dose, to not taking a statin at all. Again, we are encouraged to repeatedly de-challenge and re-challenge patients with statins to assess whether their symptoms are caused by statins and to work out the best regime for our patients. And our main statin-based approaches are either to think about trying an alternative statin or trying a lower dose of the same statin. And actually, we can even try intermittent dosing regimes as well, with alternate day or maybe even twice weekly regimes as a good option to get our patients initiated and settled on a statin, and then maybe gradually increase as tolerated. So a quick quiz question for you. If you were considering doing an alternate day or even a twice weekly regime, which statin would you prescribe? Would you use simvastatin, atorvastatin, rosuvastatin, or pravastatin? Well, actually, the evidence suggests that either using atorvastatin or rosuvastatin would be the best options. These medications have longer half-lives than the others and are therefore well suited to these intermittent dosing regimes. Now, once a regime has been tolerated, even if you've got a patient on only, say, 10 milligrams of atorvastatin twice a week, it can then be slowly up-titrated, probably every 8 weeks or so, to achieve our target LDL levels. Now, if we've got to a stage where we can't increase that statin any further, the patient's only able to tolerate that low dose and we're still not at the levels of LDL cholesterol that we want to be, then we can consider adding ezetimibe to our low dose of statin. And actually, it's been shown that ezetimibe, when combined with any statin, is likely to give a greater reduction of LDL cholesterol than doubling the dose of that statin. So there are good biochemical results associated with adding ezetimibe. It's a good option worth considering. So going back to our patients with SRM2 or 3, if we restart with our lower dose or an alternative statin and there's no recurrence of symptoms, we can gradually titrate at 8-week intervals to achieve our target LDL cholesterol levels. If the patient does have a recurrence of symptoms, there's a short time to onset of those symptoms, the symptoms are intolerable, that's when we would want to consider alternative options to our non-statin based approaches for when statins are contraindicated or just not tolerated. So the first option we've got is to consider going back to ezetimibe, 10 milligrams, but using it as a monotherapy and assessing response after 3 months. Now, some patients do very well on this and get a good reduction in their LDL cholesterol. But if we can't use statins, if our statins are contraindicated or not tolerated, and ezetimibe alone doesn't control our LDL cholesterol well enough, then we can consider ezetimibe bempedoic acid combination. Bempedoic acid is still quite a novel oral agent. It's been shown to reduce LDL cholesterol by around 28% more than placebo, without an increase in muscle-related events. So again, we get good reductions in our LDL cholesterol and it's usually well tolerated. Now, if we're still got our LDL cholesterol above target levels, despite this combination, we would then want to assess eligibility for injectables and consider referring to a lipid management clinic for these. Now, the injectables that the lipid management clinic currently have available and are becoming more widespread in their use are inclisiran and the PCSK9 inhibitors. So inclisiran is a double-stranded small interfering RNA. It increases the uptake of LDL cholesterol and lowers circulating LDL cholesterol levels. It's been shown to reduce LDL cholesterol by over 50% over 1 to 2 years, so really good reductions in cholesterol levels. The PCSK9 inhibitors act on the protein that breaks down cholesterol receptors in liver cells that are responsible for removing LDL cholesterol from a person's blood. So the more PCSK9 protein a person produces, the more their cholesterol receptors degrade and the more cholesterol remains in their blood. By inhibiting that protein, we're increasing the number of cholesterol receptors and we're removing more cholesterol from the blood. Again, these are well tolerated. Studies have shown they're tolerated by over 80% of patients, and again will reduce LDL cholesterol by around 50% with fewer muscular side effects. Now, unfortunately for these injectables, the costs remain high, and so there are strict inclusion criteria, but these are well documented in the NICE technology appraisals for these medications and also in the BNF. So it's very easy to see whether your patients are eligible and whether it's worth doing that referral to the lipid management clinic. So Going back to our spectrum, we're now down to SRM4, which is severe myopathy. These are patients with muscle pain, but a CK 10 to 50 times the upper limit of normal. In these patients, we need to stop the statin, and these patients should be referred for outpatient assessment. Once again, we think about those risk factors, other causes, indications for statin, and our lifestyle changes. But in these patients with more severe muscle damage and a significant rise in their CK, we would want to be considering alternative lipid-lowering therapies and avoiding statins in the future. SRM5 is rhabdomyolysis. So these patients have a CK more than 10 times the upper limit of normal with myalgia and renal dysfunction. So again, this is why I always check using these in any patient presenting with possible SRM when I'm checking their CK. Or it can be defined as patients with a CK more than 50 times the upper limit of normal. We should immediately stop a statin if rhabdomyolysis is suspected, and these patients need a same-day admission. They need inpatient assessment and management. Finally, we're down to SRM6, which thankfully is very rare, and this is statin-induced necrotizing myositis. We would consider this as a possibility if patients present with progressive muscle weakness and ongoing CK elevation despite their statin having been stopped. Again, this is a very serious condition. These patients need admission, but this time for immunosuppressive treatment. And again, we would want to avoid any re-exposure to statins in the future. Now, I just wanted to finish by having a little think about non-muscle related statin side effects. These vary between statins, and again, it's just worth pointing out they are not always statistically different from placebo. Again, remember that nocebo effect. Common side effects that can affect up to 1 in 10 users are GI disturbance and asymptomatic increases in hepatic transaminases. And there are a whole host of rarer side effects, including depression, fatigue, dizziness, headache, skin reactions, new onset type 2 diabetes, cognitive impairments, sexual dysfunction. Again, when trying to manage these side effects, we are strongly encouraged to consider this de-challenge and re-challenge approach to prove that these side effects or reported side effects are related to the statin. And then we can consider, if we think they are related to that particular statin, maybe trying a different statin. And the suggestion is that we go for one of the hydrophilic statins, such as rosuvastatin and pravastatin, which are more liver specific. And these are thought to cause less of these more generalized side effects than the lipophilic statins, which are widely distributed in different tissues. And the lipophilic statins are things such as atorvastatin, simvastatin, and fluvastatin. In terms of rises in liver enzymes, increases up to 2 times the upper limit of normal might be seen in the first 3 months, but we should be discontinuing statins and investigating those rises in hepatic transaminases if the levels exceed more than 3 times the upper limit of normal. So just coming back to David, our case study at the beginning, he presented with possible SRM, so we checked his CK and his Usinase as well, both of which thankfully came back as normal. Because he was suffering from intolerable symptoms, he had SRM2, we temporarily withdrew the statin. We checked his history for any risk factors for SRM, we had a chat about any possible other muscle complaints, we discussed lifestyle changes. After 6 weeks, we checked that his CK has normalised and had been symptom-free for 2 weeks, both of which were correct and had been done. And then we restarted his atorvastatin, but this time at a lower dose at 10 milligrams. And thankfully, at present, he seems to be tolerating that well. And hopefully in 8 weeks or so, we'll be able to increase that further if we need to get his LDL cholesterol down to the levels that we're hoping for. So this final slide is just the references and resources, including that NHS England statin intolerance pathway that's been the main basis for this video, and the various NICE guidances and technology appraisals that I've referred to throughout the video. I hope you found this helpful. Thank you.